Okay, and for those of you who don't know me, I'm Vern Sondak. I'm chair of the Department of Cutaneous Oncology and head of the Cutaneous Oncology program here at Moffitt. We're delighted so many of you came out early on a Saturday morning to join us for this symposium. We think you'll really enjoy the speakers that we have to say and what they have to say. As many of you who've been here already in the past know that we work on a totally programmatic or multidisciplinary model. We don't break up into little departments of surgery and dermatology and pathology. We all work together as one team dedicated to all aspects of cutaneous oncology, skin cancers of any kind, but particularly focused on melanoma. And when we see a new patient, the first thing we tell them is that the most important part of their visit is that we have to review their pathology and determine for sure that we agree with the diagnosis right from the outset. So it's very appropriate that our first speaker will be talking about that. Our first speaker is one of our newest faculty members, Dr. Tim McArdle, who is a dermatopathologist, a skin cancer pathologist, along with Dr. Jane Messina, our other skin cancer pathologist. And he'll tell you about understanding your pathology report. Tim?
So as a lot of you know, Moffitt has an agenda of really putting their best looking speaker up front. So just kind of provide the audience with some eye candy as we go along. But unfortunately for you guys, Dr. Messina couldn't be here today. She's probably knee-high in margaritas and other frozen concoctions as we speak. So, well, she was nice enough to provide me with her presentation to give to you. So a lot of people get a bill from pathology, they're mad and they're upset, and it's like, I've never seen this person before. What's he doing? And yes.
Could you speak up just a little bit?
How about that? Is that better? Yeah. Okay. Anyway, they get worked up. You know, you get a bill, you've never seen this doctor before. Who is this person? What's he doing? And the thing I try and remind people is the first thing you need to do is check and make sure it's not a radiology report. I want you to be mad at the right people. So pathology is kind of broken up to a few different aspects. One is surgical pathology, and this is what I routinely do is look at whatever the clinician biopsies or the surgeon cuts out. That's surgical pathology, along with autopsies. And then there's cytopathology where they do fine needle aspirations and small collections of stuff. And then there's clinical pathology. It has to do with hematopathology, bone marrow aspirations, and there's clinical chemistry where you get blood work, urine analysis, all these types of things. And then transfusion medicine where you get your transfusions, your platelets, your products, your plasma, and then they do stem cell collection and stem cell transfusions. So what happens to your specimen? Well, first thing is it comes to the lab, and this person gets your specimen out of a formalin bottle. They put your specimen in formalin, kind of make it rigid, you know. Tissue is kind of plastic or bendable. What we need to do is make it strong so that a knife cutting it, it won't bend. So what we do is when this lady gets it, she tries to make sense of the specimen and try and orient it, give any kind of details about what shape it is, what size it is, and then she may add things to the specimen itself. She may ink it and say that the surgeon has designated this is the lateral margin, or this is the medial margin, or this is the tip. And she'll ink it in such a way so that whenever I see it on a pathology slide, I can make sense of that, and if it goes to one edge or another, I can tell the clinician that, you know, this margin is positive, but this one's not, or it goes to the base of what you excised. And they know whenever they go back to treat the patient, that's the area they need to pay the most attention to. So after that, after she's done all this inking, she puts it in this little container, a cassette. And since it's only so big, she can only fit a specimen that size. It's really, I'm trying to get a laser pointer on my pocket. Right here, and that's what will fit in that size cassette. Sometimes it's too big, sometimes they have to cut it in half and put it in 2 cassettes. And they'll dictate that in their report, and whenever I get my specimen, I have something to go back to and tell what they're talking about so I can make sense of it. Well, the tissue, even though it's been sitting in formalin, it's not completely plastic. As you can imagine, fat, you could squeeze it. We need to make that hard. After that, they're going to a processor overnight. This thing goes through a series of processing the specimen and impregnating it with hot plastic or hot paraffin. We're trying to make a candle out of your tissue and get all the water and everything else out of it to make it stiff. So then it goes to a histotechnologist where she sits at her desk and she has this little thing where she cranks this little wheel round and round and round. And each time she cranks that wheel, it moves your tissue, which is now out of this, and is sitting on the back of this, and is sitting in like a little candle type thing. Where she cuts it, a little leaf comes off and it floats in the bath of water. So that leaf, she takes the microscopic slide and she touches it, and it picks up on that slide because the slide's charged. After that, the tissue would be clear if we put it under the microscope. I couldn't tell anything about the cellular details. So then we stain it. Your typical stain is what they call an H&E stain, a hematoxylin, an eosinocin stain. The hematoxylin will stain the nucleus blue, and the eosin will stain the cytoplasm pink, usually. So then we have the slide, and on this slide, after it's been stained, I can tell cellular detail about the specimen. If she inked one side or the other a different color or whatnot, that's when I can tell the surgeon, this side's positive, that side's negative, or the base is positive, or whatnot. And after that, it goes to the pathologist. He sits at the desk. He interprets it. As far as I know, this is probably the first time this has actually been photographed. A pathologist actually doing work. They usually keep us in the dark confines of the basement, hid away like a dark secret. But here at Moffitt, we're second floor, so we're like real people here. And then from all that work, this is what you get, and this is what's interpreted. This is actually a USF report, so I apologize. Dr. Sunday's going to get to me later today about this, but we get some clinical identifying patient information here so that we can make sure that what we're looking at matches the slide that's in front of me that also has the information, the patient's name and MR number and the surgical accessioning case, and I can match it up and make sure, because the slide looks like anybody's tissue, I need to make sure it looks like this. And then the clinicians give us a little bit of clinical history, rule out atypia. I know what that means. That means they're trying to tell me that they think maybe it's a nevus or a mole that looks funny, or a lichenoid. So maybe a dermatitis or a irritated seborrheic keratosis, a keratosis. So basically, doesn't know what it is. But he shaved it off this person, and right there's the gross description. Since this is a biopsy, it doesn't need much gross detail of what it was. And here's your diagnosis. In this case, it was a melanoma. There's a Clark 2, a Breslow. We'll go over that. Ulceration, regression is absent. Another thing I'll have to pick at Dr. Messina, I don't know what angiolymphatic invasion is, but you take the P out, and it's angiolymphatic invasion. I know what that is. It's a vertical growth phase, which I can tell that lesions already started to invade deep. In this case, it was absent. And then give you a mitotic count, and then stage it. And then she gives a microscopic description of what she saw under the microscope. A proliferation of melanocytes, not normal melanocytes, but atypical melanocytes. They look funny in some way. They were bigger, larger, irregularly shaped, or whatnot. And that's what you got. And then they grew in these irregular nests. They wasn't growing in nice, round, uniform nests. They had effaced the reedy ridges, which are these little places that come down off the epidermis. And in this case, the lateral and deep margins of the biopsy were free of lesions. So that way, when this thing gets excised, it gives me a little bit an air of suspicion of whether I should expect there to be a residual lesion on the excisional specimen, but that's not an absolute. So your entire body, from your head to your toes, are covered in melanocytes, yours and mine. So that is to say that it'd be more common for melanoma to arise on your normal skin than a pre-existing mole. It's not always the case. Melanomas do arise in nevi, or moles. So that is to say that a very early melanoma looks like a mole. Moles don't grow, melanomas do. Any mole that is changing in any kind of character, size, shape, color, or whatever, needs to be looked at and needs to be biopsied so that we can make a diagnosis. And by all means, if your mole starts to bleed, please come to us. We will help you. But it doesn't have to be obvious color change. It doesn't have to be black. It can be red, white, blue, black. If it's getting bigger, becomes elevated. If it's asymmetric, if this side doesn't look like this side, or that side doesn't look like that side, that's a symmetry. And if the border is irregular, if this doesn't have a well-defined border, a well-circumscribed edge, that will give us pause. There's several different ways to do a biopsy. When I want to see a melanoma under the scope, I want to see the entire thing. I don't want to see a piece or an edge of it. Some of the things we try and do as pathologists is try and evaluate this symmetry, and I can evaluate that on the microscopic slide. It doesn't have to be on the patient. So if I don't have the whole lesion, my symmetry is gone. My circumscription, the edge of it, I can't tell if it's trickling off or whatnot. So, and sometimes you'll get an equivocal diagnosis based on that. This is Dr. Messina's cartoon here. I don't really like it because it looks like somebody's cutting an eye out. So there's melanoma in disguise. Melanoma doesn't have to look like an ugly mole. It can look like other things. In this case, it looks just like a benign nevus. It's not colored. It's the color of the skin. It doesn't look like much other than this. And this isn't lesion. Isn't raised, discolored. It's just a bloody erythematous place on the patient's nose. Melanoma is a difficult diagnosis for pathologists, and it's one of the most litigated places in medicine. So we get nervous a little bit about melanoma. We have to be sure of what we're looking at and evaluate the entire thing and be very careful about each parameter that we measure under the microscope, and pray that our malpractice is up to date. There are mimickers of Spitz nevi, of melanoma. One of them is a Spitz nevus. It's a nevus that occurs in typically younger patients. You have nest here in the epidermis. This is the epidermis. Down here below, this is the dermis. And one thing about melanomas is they typically tend to stay along this basal layer of the epidermis, the very lower border of it. And they don't typically tend to spread to the top, which is what we call pagetoid spread. But this benign mole, a Spitz nevus, actually does that. But it's got other characteristics that help us define that, and the age of the patient and location that goes into helping us make our diagnosis. Here's what could be another mimic right here, a blue nevus. This doesn't actually involve the epidermis, but involves a deeper layer of the skin, the reticular dermis and the papillary dermis. And under the microscope, it's full of these spindle cells. Melanomas are typically epithelioid in appearance. They have round, centrally placed nuclei. These are elongated and oval and spindled, but it's benign. There is a melanoma that mimics this, a desmoplastic melanoma. So we have to be very careful about these as well. This is a congenital nevus. It looks very ugly on the patient here. It's large, it's hairy, it looks like all get out, but it's benign. Under the microscope, we see these melanocytes, like we were talking about, behaving themselves, staying at these nests at the lower border of the epidermis, and as they go down, they splay around this hair follicle that's going down to the dermis, and these, as you can see, they tend to get darker as they go down, so they're more lightly staining than they are at the top. That's really a artifact of what we call maturation. As nevus or melanocytes dive deep into the skin, they tend to lose their cytoplasm. They become what we call more basophilic because the nucleus takes up more of the cell than the cytoplasm. But that's a good thing. So there's some essential information we need for our reports. We need the clinical information. If there's been a recent change in the size, the appearance of the lesion, if there's been a previous biopsy, they biopsied, didn't get all out, a recurrent nevus versus a recurrent melanoma in the skin can look identical under the microscope, so that's important. Once again, we need patient identifying information so that report comes out to be accurate, left foot, right foot, or whatever. I can't tell that under the microscope. The name, the sex, the age. And then we need to hopefully provide with a correct diagnosis. And then I need to provide the surgeon information so he can do the appropriate therapy or whomever. And then prognostic information. So information to be used to determine in this is can be the depth of invasion. This will tell the surgeon how wide he needs to excise around the lesion. And as we measure the depth of this invasion, the margins of what he's going to excise is going to get bigger. They have cutoff points for this. And then we need to provide some prognostic information that will predict patient's outcome. Some of these prognostic parameters that we use typically in pathology are a Breslow depth, and that's the depth. We'll go over that in a second. Ulceration, a Clark level, which is kind of an arbitrary cutoff of where it is in the dermis, whether it is invaded the lymphatics. We give a mitotic rate. This will tell you how fast your lesion is growing. If it has a bunch of mitosis, that's worse than one that doesn't have any. Whether it's regression. Melanomas are very immunogenic, or they'll set off the host immune response. And it'll start attacking the tumor cells, and it'll get rid of sometimes all of the tumor to begin with. There are other things that undergo regression, but melanoma is one of them. Growth phase, whether it's vertical growth phase or horizontal growth phase. We'll go over that in a second, and some unusual subtypes. So the main prognostic information that we want to get is the depth of invasion. Now, I'll measure the depth of invasion from the top of the granular layer of the epidermis, here, this is all epidermis, to the deepest extent of the tumor. These cells right here are actually not tumor, these darkly pigmented ones. Those are the cells that are there that are gobbling up the melanin that melanocytes produce. Once the macrophages take up this melanin or whatnot, they tend to make it darker, and it can be difficult when there's a lot of that and not much of this. So you can imagine, but your epidermis is variable depending on where you're at in the body. If you get a biopsy from your toe, this epidermis is very thick. Now, if I biopsy or someone else biopsies skin from your face, it's very thin. And you have skeletal muscle and fat right up underneath it. So when you're given a Clark level, which we'll go over in a second, that can, go up or down very fast. Ulceration here, so we had the epidermis here. Oops. And now it's gone. It's ulcerated. The lesion goes all the way to the top. The entire epidermis is gone. It is ulcerated. That's a bad prognostic factor in melanoma. or an adverse prognostic factor. Clark level. So here, when it's still in the epidermis, this is a Clark level 1. If it's in the epidermis, it's confined to the epidermis, it doesn't have access to the lymphatics at this point. It can't metastasize. Melanoma in situ, or lentigo maligna, are two things that are melanoma in situ. Now, lentigo maligna melanoma is actually an invasive melanoma. Yes? Are you trying to ask him? I'm sorry, I couldn't hear that. How's that? Better? All right. So what I was trying to say is if the melanoma is confined to this layer, it doesn't have access to the dermal lymphatics, and at that point, it can't metastasize. So a very early melanoma caught, the better. Once it is in the dermis, it has access to the dermal lymphatics and has the capacity at that point to metastasize. Now, as it gets thicker and goes deeper, the chance of that metastasis is greater. Clark levels are divided 1, 2, 3, 4, 5. In the epidermis is 1. If it's in the papillary dermis, as you can tell the dermis right here, you got these thick, coarse collagen bundles here. Here, they're kind of wispy and wavy and not so much. So if it's barely in the papillary dermis, it's Clark level 2. If it's deeper and it expands this papillary dermis down to the reticular dermis, then that is a Clark level 3. And if it's in this thick collagen bundles, that's a Clark level 4. Now, if this was a thinner biopsy, then subcutaneous tissue, if it reaches that, then it is a Clark level 5. Now, what I was saying, if you biopsy somebody on the foot, then this layer is thick, so it could be in the barely in the papillary dermis, but you could have a very, or a rather thick Breslow depth, which would be different if you had something on the face. Angiolymphatic invasion, once it's in the dermis, melanomas can gain access to the lymphatics, and this is how melanomas typically metastasize, typically to sentinel lymph nodes and corresponding lymph nodes first before they go into deeper or more wider invasion or wider metastasis. Mitotic rate. So one of the things we do under the microscope is to count the mitosis, number of mitosis, and we try and count these per millimeter squared. So what we do is we try and find the hot spot of mitotic figures, and we count these, starting with that field, and then we move under my microscope, this is calibrated, 5 different fields at a 40x power, or 400x power after you include the ocular, 5 times. And then I'll report that as the mitotic rate of this particular melanoma. The lower, the better. Regression, as we talked about a little bit before, melanomas are immunogenic and sometimes cause the host immune response to come up. Here you have melanoma. Now, virtually no melanoma. Although it looks horrible, these are, like I said, these melanophytes that tend to come in and pick up all the melanin and become very darkly pigmented, but actually here there's no melanoma. Growth phase. There are 2 growth phases. A horizontal growth phase where the melanoma tends to grow horizontally along the basal layer of the epidermis and away, or maybe just under the epidermis and the dermis. Or it can be a vertical growth phase, meaning there's 2 things I use to evaluate for that. That one is if the largest nest in the dermis is larger than the biggest nest in the epidermis, then that's vertical growth phase. Or if I can find a mitotic figure within the dermal component, then that is also vertical growth phase. In this example here, the largest nest in the epidermis is larger than the biggest nest in the dermis. So this is still horizontal growth phase, considering that no mitotic figures are found within this dermal component. Now, corresponding to this is a vertical growth phase. The largest nest here in the dermis is larger than the largest one in the epidermis. And just getting from this, I can assure you that there are mitotic figures within this particular melanoma. Then there are some unusual types of melanoma. Melanoma can arise in your eye, in your retina, or it can arise in your GI tract or mucosa melanomas. This is what they call a desmoplastic melanoma. It's a little bit different than your typical melanoma. And you can see here, these are these are all nerves. And around these are melanocytes, spindle melanocytes that tend to grow out, and there's a little bit of a bluish haze, or what we call a stromal reaction, or desmoplasia, if you've seen that term in your reports. But depth for depth, these particular melanomas usually behave better than your more normal melanoma, or desmoplastic melanomas do. Here's one in the GI tract, the colon. So in summary, pathologists are seeing biopsies of pigmented lesions more frequently, as we should. It's a challenging diagnosis for pathologists, and this pathology report needs to include the various essential information to help guide the surgeon and other treating physicians in the care of the patient, and enable discussion of the prognosis of that particular melanoma.